So it is a pleasure that I present our last speaker today, Dr. Roger Dmochowski. He is a urologist and a professor at Vanderbilt University in Nashville. He is a prolific researcher with an impressive track record. And in addition to his numerous accomplishments in pelvic floor reconstructive surgery and clinical treatment for incontinence, his interests are also oriented toward patient adherence to medication. And he recently published an amazing paper on the importance of patient adherence in OAB patient, and which will be related to the topic he will be speaking about today.
Thank you.
Thank you very much.
Good afternoon, everyone. It's a great pleasure to be here and to discuss topics related to adherence and long-term persistence with recommended therapy. I'm not going to specifically focus on drug therapy per se. I'm going to take the entire panoply of interventions that we use for pelvic floor therapies and use it as the backdrop for the premise of my discussion. These are my disclosures. And I was asked to speak on compliance and persistence and the role of the patient. And as you'll see, I'm going to focus on two things, really the educational aspect of the patient and also health literacy. And I'll define sort of both of those and the overlap between them as part of this discussion of adherence, compliance, and persistence. So Professor Dean did a very nice job of defining terms. Persistence obviously is a term that is used quite a bit, at least in the United States. Also with again, the concept of a continuation of therapy. There is sort of a time difference and acuteness versus a chronicity between these terms, and I think that's important to consider. And certainly in the medical literature, you sort of see these terms being used with the framework of time, in other words, chronic versus acute intervention. What are some of the factors that affect compliance persistence with documented drug recommendations, even surgical recommendations, or for that matter, it's what's been discussed by the two prior speakers? And so patients make decisions based upon a lot of variables: the mode and type of therapy, the longevity of therapy, and their appreciation of the need for the longevity of therapy. And then, of course, the therapeutic balance, which is obviously the good, the bad, and how the two sort of balance. Is there enough effect to put up with side effect? Is there enough effect to put up with the effort that will be taken to make the effect positive? And then obviously there's something we cannot deny in any of our modern healthcare systems, and that's the cost associated with this, which increasingly is being factored into patient decision making. And many patients will make the decision whether or not therapy is in their best interest whatsoever. And they may go to their provider and decide the recommendations are not in their best interest, and they basically take the risk of no therapy. I do like this concept of the null hypothesis of clinical medicine, which some patients do take, and that is for pelvic floor issues and diagnoses. These are not generally life-threatening conditions. And again, many of these patients actually come to us with symptoms, and they'd like to have the concern regarding cancer or life-threatening aspects of their symptoms to be dispelled. The other aspect of the null hypothesis of patient decision-making is that the concept of the fact that we're dealing with chronic condition, pelvic floor dysfunction, whatever type it is, and the fact that it is a chronic condition and therapy is likely to be chronic to maintain effect. And I think one of the things that certainly happened in both the pharmacologic and surgical literature is and patients are now becoming much more aware of this. There really is no cure for many of our pelvic floor conditions. We want to abate or improve symptoms, but cure is probably not to be construed to the individual. So it's the patient-centric factors in making decisions, again, get to this concept of health literacy, what they believe to be the problem. For instance, in the United States, when you use the non-specified term bladder, referring to the urinary bladder, approximately 50% of patients don't understand the difference between a gallbladder and a urinary bladder, for instance. So there's that aspect of non-recognition of normal physiology and anatomy. Patients' expectations have to be included in these discussions because patients' expectations drive them sometimes to not accept recommended therapy, again, because of the onus that the therapy may place upon them. And then obviously behind this all is what the patient understands about their general health, their symptoms, the condition, the diagnosis associated with it, and the ultimate options for therapy. So sort of as we look at the Venn diagrams, we have the desires and expectations and patient perceptions. And again, I don't want to minimize the importance of patient perceptions. We have this knowledge, understanding, and perceptions. Again, that the knowledge and understanding and the perceptions they breed. So perceptions appears in both. And then the stuff that we sort of do in medicine, which is a diagnostic, the informatics, and the other stuff that we do to try to define and then make therapeutic planning. And obviously, unfortunately, the diagnosis and therapeutics and the other stuff tends to overshadow in many circumstances not only the initial but subsequent interactions in terms of the buy-in that we need from the patient. And so, as I said, it tends to overshadow and become the most important part of the discussion. So what is health literacy? The IOM defines, the Institute of Medicine defines health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So that's what health literacy is, and this has become a major focus for the National Patient Safety Foundation in the U.S., and really is becoming a focus of many of the surgical societies as well. Health literacy is not only a problem of misunderstanding and poor understanding, it's related to economics, and you can see the magnitude of health literacy or relative illiteracy in U.S. dollars and the proposed savings that could be construed with improvement of health literacy. Up to 17% of all healthcare expenditures are related to health literacy, and that would be enough if we were able to address it appropriately to fund all of healthcare for all the United States citizens. What about health literacy? What do we know about it? Well, we know that certainly minority groups are disproportionately affected by it, but unfortunately, the majority with low health literacy groups actually are native-born Anglo-Saxon Americans. And so this is very impactful. It really speaks to, again, the medical establishment and what we need to do to better engage our patients because of the majority of our patients don't really understand what we're talking about. This is a survey. This is the most recent health literacy survey that we have in the States, National Assessment of Adult Literacy, and you can see there are 4 categories. Notice that there are only 10% of the general population in the United States is considered to be proficient from a standpoint of health literacy. Well, what do these terms mean? Well, below basic literacy essentially are functionally illiterate or very, very poorly literate patients who really can't determine anything. They may even have trouble reading. Basic health literacy, so you have below basic health literacy, they have trouble providing 2 reasons why someone with certain symptoms might have a test, or they have trouble using clear information to make a decision. So even if it's written, they have trouble processing it. So that's sort of basic health literacy. Intermediate health literacy is to use an over-the-counter drug appropriately or to be able to identify the proper age range, for instance, when vaccines should be administered. Still what I would consider relatively basic health knowledge. Proficient literacy gets into people whose ability to calculate their health cost and utilize the information that they can glean from the internet to appropriately research a medical term, which is something that we're all seeing now. So again, looking at the distribution, look at the below basic really are a totally separate discussion from patient education and literacy standpoints, but look at the majority of the U.S. population falls into this marginally or moderately literate, but still with substantive impact on their ability to understand what's being said to them and how to process that information. So there are other concerns that we all know about in our healthcare systems, the time limitations that are placed upon us in terms of just the effort to see more patients and produce more. What is said, what is heard, a little more, I'll discuss this a bit more in the discussions that we have with patients. And what's clear now in adult education literature is in acute discussion, only 10 to 30% of the information that you think the patient should retrieve is retrievable by that individual within several hours after the meeting. So that tells you that we have to do a better job of repetitive exposure to our information. We all know that pelvic floor conditions really are actually extremely complicated conditions. The presentations may be complicated. The patients may have symptoms representative of a variety of organ systems. The issues related to pelvic floor may be indeed multifactorial in etiology. We have no cures. That complicates things. There's no really one answer for any of our conditions. And we do have multiple options for therapy. And yet, we also have differing medical opinions about what's best. And so an individual may go to 2 practitioners and get totally different things. So this, again, complicates the whole educational / literacy aspect that we factor into these discussions. What are some of the solutions for this? Well, certainly standardized educational tools. Pamphlets, whatever you may have in your office are very important, but they have to be able to be at the level the patient can understand. Verbal communication is critical, and something that we have been looking at is this concept of teach back. Expose the patient to a complicated, or at least as complicated a phenomenon as you can in the most basic language that you can, and then ask the patient to repeat back to you what they've heard, especially when it comes to the choice of options. Really critical. The other problem is that we have to come to an agreement with the individual across the table from us on what the meaning of the lexicon is that we're using. We can't be using words that are non-interpretable for the patient. So again, a critical aspect of health literacy. And then one other message from adult education is repeated communication. We have to continually re-expose the individual. So a pamphlet, verbal communication. What we do at my institution is then we follow up a written summary of the diagnostic and therapeutic recommendations so the patient can again think about them. And usually then we have another visit to again underscore the messages of these various communication tools. Better certainly than we were with a simple 10-minute discussion. Still not ideal though. This is very important for human behavior. In my operational job at my institution, I have to adjudicate the differences of opinion between physicians, providers, and emotions and preconceptions really enter into what is said and what is heard. And two very intelligent people may come away from a discussion, if they're very emotional, with totally different impressions of what was said and what was agreed upon. So imagine this overlying our patient discussions. Again, a key aspect and something that we have to prepare for, listen for, and be sensitive for, because it really does impact patient understanding. So the importance of health literacy, again, we have to establish the adequacy of information exchange. We have to provide reasonable education because it ensures adequate informed consent, which is critical for any of the interventions that have been discussed today. We also have to, again, dispel potential distractions that emotional overlays may occur, and everyone has a different method for doing that, but remember, emotions really do impact communication around healthcare delivery. And finally, we do know that an informed patient who is able to provide better informed consent actually is a more satisfied patient. And certainly in the U.S. healthcare system, and I think really in all of our healthcare systems, patient satisfaction with the delivery of healthcare is becoming much more of a focus. So as you can see, I think this is a very critical aspect of practice, one that has not been adequately amplified. As I said, the National Patient Safety Foundation in the U.S. has made this a key goal for the next few years to improve patient literacy, and I urge all of us to consider this for any intervention and any diagnosis that we use to improve the patient's ability to interact, to buy in, and to stay with that therapy that we have recommended to them for what really are chronic disorders. Thank you very much.
Thank you so much. I think it's really brought a topic that we may not all be aware of. Is there any question about from the floor?
I'm Hélène Bouchard from Canada. I was wondering, in that topic of health literacy, what have been done as including smartphones or a bit more advanced technology in terms of addressing literacy?
Well, there are, as you know, multiple ways to improve literacy, including smartphone apps. What we are clearly seeing in our work is that the average patient is actually using or trying to attempt to gain literacy from the internet. And what we have found is that, unfortunately, there's a good bit of disinformation in the internet, and part of the time we spend trying to discuss appropriate diagnoses, appropriate conditions, are dispelling some of the myths that they've obtained from the internet. So there's various methods for dispensing the information. It becomes individualized because some of the individuals are better with electronic means and some are better with paper and some are better with repetitive verbal communication.
Other questions? I may have one last question. Is there a link between literacy and maintenance? So once you gave all the information to the patient, then what can you do, or do you have any strategies to maintain the adherence or to?
So what's been shown, Kim, is that actually literacy, improved literacy, actually has a direct and parallel increase in adherence to long-term therapies, or even for that matter, short-term interventions. And you can increase adherence, as we know with pharmacotherapy, for instance, at at 6 months, we are looking at around 20% persistence with prescribed medications. So with improvement, that can be increased by as much as 2 to 3 times. So we're looking at 40 to 50%. So, but again, it's the appropriate expectation setting and appropriate knowledge that underlies that expectation setting.
So thank you very much, Dr. Dmochowski.
Thank you.
And I would like to thank you all for coming. So I hope that this roundtable really challenged your mind and that you will be able to bring back this all information to your patient. Thank you.